Good morning, everybody. Um, Everybody that knows me by Sammie, not by Peter, but hey, let's do this. Let's set your team up for success. So we were taught in school that cardiac pulmonary bypass is that controlled state of shock. I think that our profession is a controlled state of post-traumatic stress disorder. So the strategies nowadays that a lot of people have to deal with are dealing with educational awareness, your peer support, stress management techniques, work-life balance, debriefing sessions, and supportive leadership. That's where we have our onboarding pathway. And this pathway is to familiarize and introduce perfusionists to the team, to minimize that stress, transition them to be successful perfusionists, to allow them to relax, play the game well, and be a team. It's divided into 4 phases, and these phases progress as they go along. We have the objectives, accountability, and validation. Now, all these can be utilized not just in the pediatric realm, but as staffing orientation to perfusion practice. In phase 1, we socialize with the team, introduce them to everybody else, the surgeons, kind of icebreakers, as we say. We perform, clinical testing, understanding the equipment in point of care and bedside issues. So again, by introducing those individuals, surgeons, anesthesia, all our policies at Texas Children's Hospital, and our daily routines and clinical call schedules. And we also go over fundamental skills. It's funny, going over to Texas Children's after 25 years, I had to go through sterile techniques, scrubbing my hands, critical importance going over the heart-lung machine, especially when it comes to setting our flow constant. We even have multiple areas of equipment and storage. So we have cabinets, our core, and our stock room. To familiarize an individual with all those, we even have little fun things to do, like a scavenger hunt. So our blood conservation equipment, familiarized with the heart-lung machine, as well as accessing drugs in the Omnicell. We need passwords, fingerprints, testing, and also with point of care. Everybody knows this is our bane of existence. With the point of care, we have to go through the blood gas analyzer, anticoagulation machines, making sure that we're compliant with all aspects of perfusion. In phase 2, we get knowledge of the equipment, understand the physiology, our primes, and surgical considerations with patients and their age. Because our patients are just adults, they go from newborns to 100-year-old patients. So we have to take into consideration all the different aspects of that. The first one, in week 2, after the introduction, we go over our circuits. So we have 3 circuits that in combination can make up to 6 circuits. And our protocols associated with that. And understanding every day you have to make the right settings in the heart-lung machine. In week 3, we start to assemble those circuits. And then start understanding our prime recipes. Because of these variations, we have different recipes for each different circuit we use, and then those are adapted further to make them as accurate as possible to meet the patient's needs. The 4th week, we set up and prime not just the circuit as our cardiac circuit because it's separate and independent. And in addition to that, we add the next week, we'll do setups, cardioplegia, and even the cell saver. So it's a progression as we go along. The accountability, understand safe use of the membrane oxygen. Select the appropriate supplies, cannulas, and other things, depending on the patient's needs and weight. And demonstrate appropriate circuit components and using sterile technique. Our physiological circuits are adapted individually and fine-tuned every individual patient. The validation procedures, we go over everything we know, everything we learned as a student, the heart-lung machine, the venous saturation monitor, heater coolers, cell savers, vaporizers, where we deliver our anesthetic gas, vacuum venous assisted drainage. And in these validations, we got to make sure we stay within our parameters and stay and match our acceptable venous blood gases, arterial blood gases. In phase 3, we perform clinical supervises. We actually finally get the pump. It takes a while. So do that and start to begin with our emergency drills. So as we begin to perform in the objective, we begin with entry-level cases, moderate-level cases, and then complex. We demonstrate the problem-solving skills that are associated with that. And at the end of this, with our preceptor, we end up having a buddy call. So you shadow the person that you're with. So a typical assignment from 6 to 8 weeks is where you begin pumping supervised cases. Not many institutions take 6 weeks to train someone. It's usually trial by fire. So, and then 8 to 12 weeks, you begin moderate complex cases, and then 13 to 24 weeks. Yes, see that. 6 months to finally get to a point where you're starting to think about taking a role. So your accountability, you want to perform these successfully and safely. Entry-level cases. Again, our entry-level cases include blood primes. What you don't really realize is that our clear prime cases are significantly more difficult than our blood prime cases. And the reason being that human dilution in our crits starting in the 50, 60 range, 55, that dramatic decrease with hemodilution makes it difficult to manage their pressures. So it's easier to do a straightforward ASD small kit with blood prime or a medium-sized kit than it is a kit that was a larger, which we consider our moderate level cases, in a larger ASD that's clear primed. And then in addition to that, we have our complex cases, which include coronary perfusion and also exchange transfusions when we do exchange transfusion, ABOI, incompatible heart-lung transplants. Our validation criteria, and the funny thing is, we've adapted, all of us, actually everybody on the team, are all THI grads. We've adapted our own version of the grading scale so that we make sure that the proper flow is selected, cardioplegia, valve sizes, all that is calculated every day. Our cannulas, initiation of bypass, was it done smoothly, was it not? And predetermined patient pressures, communication in the room. The accountability is to demonstrate these to acceptable lab levels and meet our criteria. The validation, potassium, sodium, calcium, and other labs that we want to make sure that they stay within range. Accountability, demonstrate if your oxygenator is working, if you're having a decrease in your SpO2, are you going to make the right adjustments? By increasing your flow rate, increasing your hematocrit, and effectively communicate with those around you. Parker Palmer in 1984 developed the idea of circle of trust. And in that circle of trust, that us as individuals, as perfusionists, need to communicate with the surgeon, anesthesia, the nurses, the people that bring us the blood, so we can plan appropriately, plan ahead, so that our life isn't as stressful as it is. So I'm going to orient and meet all these requirements. And once a person gets this far, are they able to go on to the next level? To level 4, where you can perform everything independently and on your own. And by performing performing these, we would have to do at least 20 complex cases successfully, and just demonstrate critical thinking, and have our buddy call and mirror our preceptor. By week 25, you should be doing entry-level pieces on your own. 26, moderate level to complex on your own. And 27, you have unsupervised complex cases. So now we're looking at 6 months in our onboarding. Then you begin your safety drills to make sure if you are by yourself, you can handle this. Your validation includes your oxygen replacement and things you do. And you'll be able to change out a pump head should your pump be unreliable. There's many other safety ideas that we throw in here, but I didn't want to go over them all. And here's the validation for each of those, how to perform the test. So the orientee not meet these successfully. Unfortunately, we've been in this situation also. And it gives everybody in HR the documentation to do the appropriate. Not everybody's cut out to do certain jobs. But once they do that, the employee can demonstrate and fulfill, have all this document. We have folders and folders should, for some reason in the future, you can reference back our training and development in congenital heart surgery. So our low frequency skills checklists, we perform those. And then we start to orientate an individual around the hospital. We go over our advance, priming our Berlin hearts. We go over ECMO. We sit at ECMO and do, even though we have an ECMO team, we spend the entire day priming, doing the circuits, should we be needed elsewhere in the building. And here is our recall checklist. As you can see, very complicated. We have multiple places within a single institution where we have to make sure if we're in the general OR in one tower, or in the general OR in the main tower, or legacy tower, or in our OR, on the floors, or IR. So we need to familiarize our individuals with all these locations. So you can adapt this and bring it to your institution also. You can minimize incidents by improving patient outcomes. So this is what we're here for, improving patient outcomes. And by doing that and being able to play the game, enjoy the game, you perform better. You set up that new team member for success and familiarize them with everything. And then you maximize the financial aspects of the onboarding process for the hospital, because it's important. The hospital makes a lot of investment into you as an employee, and you want to be able to do the best and give the best care. And as a result, better care for our patients while improving the mental health and well-being of ourselves. Thank you.